Welcome, my friends, to the Bob and Brad podcast. My name is Mike Keenitz, and I'm a PT assistant. Today, I'm interviewing Rick Olderman, who is a physical therapist, and I'm going to ask him different shoulder and arm pain questions that you, our audience, had for him. Things like rotator cuff or forearm injuries, even upper trap issues. So, without further ado, here is Rick. Welcome back, Rick. Thanks for joining us again.
Great to be here again, Mike. Thank you.
Today, we're going to be talking about shoulder and arm pain. So, we have questions from our viewers. And our first question is actually from a therapist. So, they say, I'm a therapist who works with athletes. And this year, it's overhead athletes. What are the best stretches and treatments for sore shoulder complexes?
All right. Well, I'm so happy that we got a question from a therapist. That makes me really happy. This is really interesting because just this morning I was answering a reporter's question about the serratus anterior. So this will play into this quite a bit. So it's important to understand that when we move our arm away from our body, the foundation of all of that movement is the shoulder blade. All right. And if you look at the architecture of the shoulder blade, you'll see that it's a broad flat bone. There's only one other area in the body that has a bone like this, and that's our pelvis. And we all know that the pelvis is the center of function for our back, pelvic, and lower body system. Likewise, the shoulder blade is the center of function for our upper body system, neck, and head. All right. So there are rules about how the shoulder blade should be resting and moving. I won't go into all of those rules, but in overhead motions, one of the things that should be happening is that the shoulder blade should be rotating 60 degrees. Now, clinically, what I have found is that if I can get someone to 40 or 45 degrees, that's enough to have pain-free overhead motion. But 60 degrees of upward rotation of that shoulder blade is ideal. So what I would first say is, hey, is this person getting 60 degrees of upward rotation? And I would guess if they're a therapist, they're probably working with someone who's had surgery. And if they've had shoulder surgery, what often happens is our focus in therapy is to get the arm mobility up and going. But very few of us seem to be focusing on the scapular portion of that mobility. So if we think of the arm as having 180 degrees of ideal movement, I mean, I wish I had that, I don't, but 120 of that should be coming from the shoulder joint itself. 60 degrees of that should be coming from the shoulder blade. So usually this is where the problem is happening, is that the shoulder blade is not going through its elevation and upward rotation, which then causes the arm bone to bump up into the top of the acromion too soon. The other thing that it causes is that if this isn't moving, then we rely on the rotator cuff and deltoid muscles to do the arm lifting. That then causes more tendonitis issues in the shoulder area because it's overcompensating for the lack of mobility that's occurring here. So that would be, I bet you this is probably the problem. And it's most common after shoulder surgeries. One of the reasons, and I mentioned this at the beginning, is because I find that after surgeries, the serratus anterior, so the serratus anterior is this really weird muscle. It starts along all of these vertebrae right here, and it goes underneath the shoulder blade and inserts along the back border of the shoulder blade here. It's the muscle that's responsible for the upward rotation of that shoulder blade when the arm bone is moving. And this is what I found is after surgeries or trauma to the shoulder of any kind, the serratus anterior seems to lock down the shoulder blade and prevent it from moving because it's trying to protect the shoulder girdle system. All right. But as we come out of that acute injury or surgery or something like that, we need to try and coax that movement back into the serratus anterior again. And so I've developed a nice nifty mobilization technique to get that to happen. But to do that without a manual technique, one of the easy ways is if you get someone on their hands and knees on the floor and their hands are here on the floor and then they sit back on their heels with their knees bent, what that's going to do is it's going to relatively pull the arms up overhead, and it starts to get the shoulder blade to move the way it should without actually asking the muscles to do the job. It's just the arms are essentially going to be pulling the shoulder blade into that upward rotation and elevation, and that starts to restore normal scapular movement. And then what you can do eventually, once that scapular, and you can assist with your hands too, as a therapist, to help that scapula move the way it's supposed to. All right. And then what you can do is gradually, once that motion gets more normal, then you can use the legs to add resistance to that system. So now as you're rocking back, the legs are pushing forward. So your arms actually have to push your body back, which engages that serratus anterior in the upward rotation and elevation motion that's designed to do. And it starts to strengthen that system while you're also getting the movement that it's supposed to go through. So that would be my general answer, is to look at the scapular landmarks and fix those, because that's and if the landmarks are off, it's usually a serratus anterior issue.
So once someone's healed up, could they just hang from a pull-up bar and get the same type of stretch?
Well, you can, but if that serratus is locked down, so this is the other aspect of shoulder motion, is that there's a timing issue. So after the arm gets to be about 60 degrees or so of movement here, there's a 2-to-1 humerus to scapular ratio of time that should be occurring. So if this isn't occurring, what's typically happening is that, I'm glad you brought this up, Mike, because this is a really common thing. So what happens is that after a surgery or something like that, when the arm comes up, and you see lots of scapular motion. Well, that's because the arm muscles, the teres minor and infraspinatus, are pulling the scapula along, rather than the serratus anterior pushing the scapula along. So by hanging, what you're doing is, yes, you may be pulling that scapula forward, but you're not teaching the muscles to do the motion that it's supposed to do. And this is another really common thing, is that I'll see, oh yeah, gosh, that person has a 60 degrees of upward rotation. And I look at the timing, and it's a 1-to-1 relationship. And if it's a 1-to-1 relationship between the arm bone and the shoulder blade, it's telling me that these rotator cuff muscles are locked and they are not changing. And so that it just moves, with the arm bone. That's the only thing that's making the scapula move, instead of the scapular muscles making them move.
All right. Well, thank you for joining us again. Where can people find more information about you at?
If they go to rickolderman.com, I have lots of free stuff there. I have some blogs. I have all my home programs, my practitioner training program, and there's a contact form there, of course, for me that you can use to reach out if you like.
Okay, perfect. Well, thank you for joining us.
My pleasure, Mike. Thanks for having me.